Hi, my name is Song-Hee Kim, and I am an assistant professor of data science and operations at the USC Marshall School of Business. Even though social distancing measures helped many hospitals avoid initially expected resource shortages, hospitals need to continue to be ready for a surge of COVID-19 patients. As a running example, I will focus on ventilators in this presentation. But the idea applies to any scarce hospital resource, such as ICU beds, staffing, and personal protective equipment. Hospitals need ventilators to help severe COVID-19 patients keep breathing. It is estimated that about 62,000 ventilators are owned by about 5,700 acute care hospitals in the US. This means an average hospital has about 10 to 11 ventilators. With the fast-growing number of COVID-19 cases, especially at the beginning of the pandemic, hospitals in certain cities had a critical shortage of ventilators. The US government is spending almost $3 billion to produce about 187,000 new ventilators by the end of 2020. The goal is to make sure that a ventilator is available for every patient who needs one in a timely manner. As individual hospitals prepare for a potential surge, how many ventilators do they need? I'm going to address this question using queuing theory and research findings from the field of hospital operations. The first step is to collect data. Using COVID-19 projection models, each hospital needs to predict how many new patients will require ventilator support each day at the peak of a potential surge. Each hospital also needs to estimate the average length of ventilator support per patient. Because most hospitals have cared for COVID-19 patients by now, they can use past patients' data from the electronic medical record and estimate the average length of ventilator support for their patient population. The second step is to estimate the average number of ventilators needed using Little's Law. Little's Law, developed by Professor John D. Little at MIT, is a fundamental queuing relation. It says that the average number of customers in a system is equal to the arrival rate multiplied by the average time in the system per customer. Little's Law is powerful because it shows that if you know any two of these quantities, then you know all three. You can also use it to predict how changing one of the quantities will affect the other quantities. Applying Little's Law, each hospital can predict the average number of ventilated patients at the peak of a surge. Let's suppose that Hospital A collects their data and predicts that it will have 2 new patients needing ventilator support per day, and that each patient will need ventilator support for 5 days on average. Hospital A can predict that on average, there will be 10 ventilated patients in the hospital. Does this mean that Hospital A needs 10 ventilators to meet demand? The answer is yes, only if there were no variability in the system and no effect of high utilization. What do I mean by variability in the system and effect of high utilization? I will use results from queuing theory and findings from recent research to explain them next. To understand the effect of variability, let's examine a hypothetical situation where Hospital A has exactly 10 ventilators and there is no variability. Hospital A has exactly 2 new patients arriving each day, and each patient requires ventilator support for exactly 5 days. Once the system stabilizes, there are exactly 10 patients who need ventilator each day. There is a perfect match between supply and demand of ventilators, and Hospital A's 10 ventilators are being utilized 100% of the time. In reality, there is variation in the arrival pattern of patients, as well as variation in the length of ventilator support. The arrival rate is still 2 patients per day, and the average length of ventilator support is still 5 days. The difference is that on some days, Hospital A has 1 patient arriving, and on other days, 3 patients arriving. Some patients are on a ventilator for 4 days, and others are on a ventilator for 6 days. Because of this variability, when patient 11 arrives, all 10 ventilators are in use, and the patient needs to wait about 1 day to be on a ventilator. The red boxes indicate the delay each patient experiences due to the variability in the system. Because of variability and the fact that new patients will continue to enter the system regardless of the system status, the delay can get bad much faster than our instincts might suggest. Timely access to ventilator is critical, and such delay should be avoided as much as possible. Then how many additional ventilators does Hospital A need? We can use queuing theory to determine that number. Here is a figure that plots the average delay in days for each number of ventilators from 10 ventilators to 16 ventilators under reasonable assumptions about the variability in the system. It shows that with 11 ventilators, patients will wait on average of 3.4 days for a ventilator. With 15 ventilators, about 4 hours. The bottom line is that hospitals must incorporate additional ventilators beyond what is predicted by Lewis' law to account for the variability in the system. In fact, the average number of ventilators needed, predicted by Lewis' law, can be thought of as the minimum number of ventilators that you need. If Hospital A has 10 or fewer ventilators, then the queue of patients waiting for ventilators will continue to grow, a state called unstable in queuing theory. There is one more reason why hospitals need more ventilators than what is predicted by Lewis' law. Ventilator utilization is defined as the number of ventilators in use divided by the total number of ventilators times 100. Utilization is often seen as a measure of efficiency, and higher utilization is usually viewed as desirable. However, research in healthcare operations management over the last 2 decades has shown that high utilization in hospital settings may not be so desirable. This is because high utilization may have a negative impact on care delivery and patient outcome. One study found that a highly utilized ICU leads to patients being discharged prematurely, increasing the risk of ICU readmission. My own study showed that a highly utilized ICU leads to patients being denied admission to the ICU, which in turn increases the risk of hospital readmission and total hospital length of stay. Another study found evidence for the existence of safety tipping points, which are levels of hospital utilization beyond which patients are exposed to higher mortality risk. The same argument can be applied to the use of ventilators. If the ventilators are highly utilized, then some patients may be prematurely taken off of the ventilator to make it available for another patient. Some patients may even be denied ventilator support, all of which can lead to worse patient outcomes. The figure shows the average ventilator utilization as a function of the number of ventilators for Hospital A. This figure again illustrates that Hospital A should have more ventilators than what is predicted by Lewis' law to prevent the potential negative effect of high utilization on patient outcomes. There is much uncertainty around the progression of COVID-19 infections, and accurately predicting the number of new ventilator patients at the peak of a potential surge is challenging, if not impossible. The average length of ventilator support may also change over time. In determining the choice of patient arrival rate, or average length of ventilator support, it is important to consider how these parameters may change and understand the sensitivity of ventilator requirements to these changes. After that, hospitals need to keep monitoring the progression of COVID-19 infections and make adjustments in real time. As hospitals try to reduce ventilator requirements, they can consider sharing ventilators with nearby hospitals. Service systems with variability have economies of scale such that larger systems can operate at higher utilization than smaller ones, yet maintain similar levels of delay. This is because bigger systems can handle variability better. For our example of Hospital A, let's suppose that there is Hospital B that looks exactly the same as Hospital A. Hospital A and Hospital B agreed to share their ventilators and establish efficient case sharing and transport between the hospitals. By having 11 ventilators at each hospital, the average delay will be 1.4 days, which is almost a 60% reduction compared to not sharing ventilators. In fact, regional networking among 15 hospitals was part of Lombardy's early response to the massive surge of COVID-19 patients. There has also been many efforts to establish ventilator sharing across hospitals, across states, and even across countries. We can use Little's Law to think of other ways to reduce ventilator requirements. According to Little's Law, decreasing the average length of ventilator support, for example by developing a drug that reduces ventilator days, will decrease ventilator requirements. The figure on the left shows the change in the delay if Hospital A can decrease its length of ventilator support to 4 days from 5 days. Little's Law also shows that decreasing the arrival rate will decrease ventilator requirements. The figure on the right shows the change in the delay if Hospital A can decrease its arrival rate to 1.75 patients per day from 2 patients per day. The effect is dramatic. Hospital A can achieve an average delay of about 8 hours with only 11 ventilators. Notice here that decreasing the arrival rate will result from flattening the curve. By flattening the curve, we make sure that hospitals will have enough ventilators to provide care to patients with shorter delay. There is still uncertainty around COVID-19, and healthcare needs exceeding the system's capacity could hit any region at any time. The cost of not preparing could be huge. The actions taken now by our society and healthcare systems will determine whether healthcare systems will have enough resources to provide the right care to the right patient at the right time. Thanks for watching.